Hello everybody and welcome to chapter 33 from module 8. For this voiceover we're going to just take a look at all the non-infectious lower respiratory problems. This slide just gives you a picture of the impact of asthma on healthcare. A lot of healthcare dollars goes into asthma and a lot of these non-infectious lower respiratory disorders. I think Heather on her presentation really discussed that, about how much money is going into it and how we really need to be advocates to make sure that it's treated properly to keep people out of the hospital and try to keep the cost down as much as possible. So the number of people with asthma is rising. A few different reasons that might contribute to this. Maybe we just have a better understanding of what asthma is. We're diagnosing it more than we used to. And it could be the environment. The changes in the environment are creating more allergens and environmental factors that's causing the incidence of asthma. So what is asthma? Asthma is a chronic inflammatory obstructive disease. It's almost what a lot of people will call a reactive airway disease. It can occur at any age, and it's usually characterized by wheezing because of airways or spasming, tightness in the chest, breathlessness, and cough. The signs and symptoms may remit spontaneously or exacerbate in response to environmental triggers or stress. The severity of asthma is highly unpredictable. It could be a mild attack or a very severe attack that could completely obstruct the airways. It is a reversible hyperreactivity of the bronchi. So it's your bronchioles being hypersensitive to something in the environment, and it causes an inflammatory response. This inflammatory response is reversible, like Heather said, with the proper treatment. With removal of the allergen and proper treatment, we can reverse this to where the patient is back to breathing normal. However, they still will always have the diagnosis of asthma, but the hyperactivity of the bronchiole and the inflammation is reversible in an asthma patient. So how this sort of happens is once it's like, just like we talked about when we talked about like allergic reactions, when your body identifies something as foreign, as a stressor, it will release all of these defense mechanisms, and that includes like mast cells, eosinophils, which I think Heather talked about, lymphocytes, neutrophils, and they directly infiltrate the airway at the smooth muscle and the basement membrane layer. So that's how this inflammatory response constricts the airway and causes wheezing. So the big thing to remember that's on this slide is the fact that it affects the airways, not the alveoli. If you recall talking about COPD and emphysema in contrast here, the alveoli are affected by the emphysema. So in asthma, the alveoli are not affected. It's just the airways from the inflammation, from the hyperactivity to some kind of a environmental or stressor. So this is a really good picture here to kind of help you understand the pathophysiology of it. This is all your normal bronchial tube and alveoli down here. And this is what it looks like on the inside. This is smooth muscle tissue. This is normal. That's how the air gets through. And then here is an asthmatic, when they're having an asthma episode, see how the swelling occurs within this area, and it very much constricts the airway here. So that's kind of what it looks like, and why you hear the wheezes and why they are having hypoxia and difficulty breathing. So talking about the etiology of asthma a little bit further. Typically, patients with allergic asthma have a history of other allergies. So, there are people who are already hypersensitive to environmental things. Other environmental pollutants can trigger asthma attacks, such as pollutants, tobacco smoke, gases, nitrogen dioxide, things like that can provoke asthma. Exposure to secondhand smoke as a child can sometimes be associated with a higher risk for increased severity of asthma. Agents found in the workplace, such as noxious fumes and gases, may also cause an occupational asthma. Respiratory infections, viral in particular, are a common internal stimulus for an asthma attack. Exercise-induced asthma is also common. It can affect about 40 to 90% of people with bronchial asthma. And that's just essentially just the stress of the exercise, maybe especially with the cold weather or warm weather can actually trigger the asthma. So these are signs and symptoms of asthma, and these are pretty obvious signs. That wheeze is probably the biggest key to asthma, because they have that constricted airway. Of course, they're going to have an increased respiratory rate. They're going to be fighting harder to breathe to bring that air down into that constricted airway. A cough could be from inflammation and all these eosinophils and everything heading to the bronchioles. It's causing some secretions that they can cough it up. They're going to use their accessory muscles because they're working harder to breathe. Barrel chest, typically from air trapping, that happens over a prolonged period of time with poorly controlled asthma. Typically, they usually have had severe asthma for a while before they get the barrel chest. The long breathing cycle is that they're breathing in, and then their exhalation and inhalation are a little bit longer because they're fighting so hard to pull that air through the constricted airway. Cyanosis, that's pretty obvious because of the poor oxygenation. It's going to make them a little cyanotic, especially during an acute attack of asthma. And hypoxemia is low oxygen levels in the blood. Again, this is just summarizing how it would be diagnosed laboratory-wise. If somebody has the signs and symptoms of asthma, they'll do some labs and check for eosinophils, maybe in the sputum or in the high levels of eosinophils in the serum. And that can be indicative of asthma as well. So this is just, again, speaking to that spirometry. That is the most accurate pulmonary function test, are the way to absolutely confirm a diagnosis of a non-infectious lower respiratory disorder, because it tells us how much vital capacity they have. And like I said, don't worry too much about these numbers at all. Just understand what a spirometry test is. And typically with asthma, they'll do this pulmonary function test. They'll do spirometry like at baseline. And if you recall, Heather said this is not something you would do when somebody's having an acute exacerbation, because their forced vital capacity is going to stink. But you want to sort of get a baseline of what they are, and then give them a breathing treatment, and then check them again. And that kind of helps us. It's a very measurable way to tell us if the medication is effective for opening up the airway for the patient. So the big thing with asthma is teaching the patient to control and do self-management. If they can manage their symptoms well, then they can function normally and have a good quality of life. But the good management is going to keep them out of the hospital, it's going to save them money if they manage it and they understand their meds and they take their medications as ordered. On page 604 in your book, you have chart 32.3. It's a step system for medication use and asthma control. I highly recommend that you review this. This helps you understand the steps in how we treat asthma, and which is recommended by Gina. If you recall, that this comes right from Gina that Heather mentioned in her presentation. So these are the recommendations, the latest and greatest on how asthma should be appropriately treated. And if it's appropriately treated, the patient can have a good quality of life and stay out of the hospital. Another thing I want to point out to you, of course, is, somebody who's asthmatic does not want to smoke or be around someone that smokes. It could be an irritant that could create an asthma attack. So on page 605, there is a table about smoking cessation. It's how we sort of help someone talk through learning, to stop smoking, and how we can effectively support them through that. So if an asthma patient is monitored effectively, they will be given something called a peak flow meter. There's a picture of one on page 606. It's figure 32.4. It's a typical peak flow meter, and it just gives them a way to kind of do like a little mini PFT, a little mini pulmonary function test on their own, and they can see like if they're getting worse or better. It just kind of gives them a measurement, and the doctor can tell them like if it gets to a certain point they need to call or use their inhaler. There's instructions on page 606 for using a peak flow meter. That basically, it's sort of almost like a IS type thing where they blow through the mouthpiece as hard and as fast. So it's opposite, so they're breathing out instead of breathing in. But it is a way that they can sort of manage themselves at home and try to make sure, determine whether they need to use their inhaler, if their inhaler's effective, if they need to call the doctor. It's ways that they can kind of identify problems before they're in the hospital. So drug therapy for asthma, typically it depends on the patient's severity of asthma, but a lot of times they have to be put on what is called a controller or preventive therapy. So it's a long-acting beta-2 agonist typically, or a cholinergic agonist. Those are both bronchodilators, but they are long-acting bronchodilators. A long-acting beta-2 agonist, long-acting bronchodilator is Ceravent or Salmeterol. That is on in your book. So it's long-acting. So basically what that does is it controls their asthma symptoms. And then the other one is the cholinergic antagonists are also, they cause bronchodilation as well. A very common one is ipratropium, or otherwise known as Atrovent. That's a pretty common anticholinergic bronchodilator. The other thing that they might do, depending on the patient, is give them a combination long-acting inhaler, which would be it'd be a combination of a long-acting, maybe beta-2 agonist, along with an inhaled corticosteroid. So the steroid keeps the inflammation down, and it keeps them from occluding their airways from an inflammatory response. So it's like an anti-inflammatory type thing. Flovent is a corticosteroid. It's an inhaled corticosteroid on its own. Like I said, they can take these like in a combination nebulizer, or they can take it. They can take them separate. These days, typically they're given like Advair is one that is a combo of anti-inflammatory and long-acting bronchodilator. And they're just finding that's much more convenient for the patient, because instead of 2 inhalers that they have to do, they can do one and get it all in one, a couple of puffs from one inhaler. The one thing to make sure that you take a peek at when you're looking through these meds is the side effects. Now, an inhaled steroid does not have the same systemic effects as like a prednisone, the oral steroids, and that's the benefit of doing it as an inhaler. But they can get some like thrush in their mouth from the taking the anti-inflammatory med in their mouth. It decreases their inflammatory response there, and it opens them up to like an infection, because it depresses their immune system in their mouth area from inhaling it there. So after they inhale a steroid, they need to make sure that they do really, really good mouth care afterwards. They need to rinse their mouth out really good so that they don't get like a super infection type thing in their mouth, like a thrush. And the other piece of that is a lot of times they'll just keep on hand a rescue drug, which is usually albuterol. It is a short-acting beta agonist. So it only lasts for a couple of hours, but that's the rescue drug. That's what we have right now is albuterol, and it's short-acting. Okay, so I'm just going to, I've already talked about a few of these bronchodilators and such, but I'll just kind of review them again. Again, like I said, your short-acting bronchodilators would be your albuterol, commercially known as Provenil or Ventolin. Side effects of your short-acting bronchodilator typically are as tachycardia, palpitations, kind of a tremor. It can cause them to feel a little bit jittery, especially if they're using them a lot. These breathing treatments, I don't know if you've seen your patients having these breathing treatments yet in the hospital or somewhere else. They can be like an MDI is refers to a meter dose inhaler. So that's like a little inhaler that they carry around with them. These medicines can also be given via a nebulizer, which is sort of that pipe-looking thing that you see patients with possibly, that's hooked up to air, and it nebulizes the medicine, and it looks like a steam type thing that they're inhaling, and then that's the medicine that goes down into their lungs. Long-acting bronchodilator, Ceravent is an example of one. these are typically, it's recommended that you typically give these with a corticosteroid as well. But basically, they're beta 2 agonists that dilate the bronchioles. It opens up the actual bronchioles themselves. And they're longer acting so that people don't have to take them as often. It's sort of considered to be a maintenance drug. And it should not be used as a rescue inhaler. Anticholinergics are, again, they have an effect on the body that opens up the airway. It bronchodilates. Atrovent is a common name, or ipratropamine bromide is the name of an anticholinergic. Again, its effects is that it bronchodilates. Anticholinergics are known to dry up a patient. They have a drying effect. So these are contraindicated in patients who have glaucoma, anything else that would contraindicate something that would dry them up. If it's somebody who's already dehydrated, it probably wouldn't be the best idea for them because it is kind of a drying medication. The anti-inflammatory agents, again, is your corticosteroids. That's your Flovent. You have Pulmonary listed on your module outline as well. And again, these decrease the inflammation that's caused by the antigen or the allergy, the allergen that's in the environment. So we're trying to decrease the effects of the inflammatory response. And again, they feel like the best way for maintenance therapy for somebody with asthma is like the combo drugs that bronchodilates, the long-acting bronchodilator, along with the anti-inflammatory agent. Your leukotriene antagonist, again, is a drug such as your Singulair, also known as Montelukast, and it basically what it does is it decreases that inflammatory response related to an allergic reaction. One additional thing I just want to mention about these steroids, these are all great, or not just the steroids, but all the inhalers. These are great when these medications are used and used well, but if you've ever watched someone use a meter dose inhaler, it's a bit tricky to do it appropriately. There's a lot of instructions for it. Basically, the patient has to blow the air out of their lungs, and then kind of breathe in, and then use their puff into their mouth, and then breathe it in and hold it, and then release. So there's an amount of cognitive ability and physical ability that they have to have in order to be able to inhale this medication appropriately. So that's just always something to think about. Are these people using it effectively? Are they doing it right? I've seen people who just sort of squirt it in their mouth, and that's not the appropriate way to take it. You literally have to make sure that they take a deep breath in when they squirt the medicine in order for it to actually get down into their lungs, for the medicine to get down in there and open it up. On page 609, chart 32.8 is a table about how to use an inhaler correctly. It talks about making sure that it's clean, making sure they remove the cap. Typically, they have to shake it. There is something called a spacer. There's a picture of a spacer on page 609 as well. And basically what that does is it kind of holds the medicine like right in the chamber there, that spacer, and then they can take a deep breath. So it's a little bit, a lot of kids use a spacer to kind of help them make sure that they get the medication, that it's not just squirted into the air. So that's something to always take into consideration with these meds. They're not the easiest meds to kind of, just squirt in your mouth. So we'll have to do some patient education with that. And one more comment on the long-acting beta 2 agonists that are considered to be a controlling med, and the steroids, and like the leukotriene antagonists, like the Singulair. Those drugs need to be taken every day because they're preventive and they're maintenance. So just like Heather was saying in her presentation, when they come into the hospital, we need to make sure that we continue those. We need to find out what they're on and continue them, because that's what's keeping them under control. Once we stop those, then they could go into an asthma attack or something. So we need to make sure we're aware of that. Status asthmaticus is a severe life-threatening asthma attack, essentially. It's basically where it's a very, very, very severe asthma attack that is not responding to its usual treatment, and it's kind of like the asthma attack that won't stop. These patients will typically be extremely short of breath, extremely having a really difficult time, really struggling for air, and very hypoxic. So it's important that we treat aggressively and quickly. This can develop into pneumothorax, which means a collapsed lung or cardiorespiratory arrest. So we've got to make sure that we identify it and treat it aggressively. Typically, they'll give them something called like an epinephrine breathing treatment called racemic epinephrine, and it basically helps to open the bronchioles very quickly. We'll give them a series of breathing treatments, and we're going to use that rescue breather. We're going to use that albuterol, that short-acting albuterol for these kinds of patients. They'll go ahead and usually give them an IV dose of steroids because they want it to work quickly and they want it to decrease that inflammation. And then, of course, we'll give them some oxygen to support them. But basically, it's an asthma attack that will not stop. It's a severe asthma attack, and if not treated, then it's life-threatening. So it's important that it's treated aggressively, and the patients typically will recover from it, but they just have to be treated aggressively. And then the other thing about it is they just have to have education about preventing this from happening again. They need to be on medicines that control they need to be on those management inhalers, and so that they can manage their asthma and that things like this doesn't happen. This is pretty much just a review of the things that Heather talked about. Emphysema and chronic bronchitis are both under the umbrella term of chronic obstructive pulmonary disease. Chronic bronchitis is that chronic inflammation within the bronchioles and the inflammation. And then your emphysema is more the disease that affects the alveoli, and it causes air trapping in the lungs. And again, this tissue damage is not reversible. It increases in severity, and it can eventually lead to respiratory failure. So our goal for these people is aimed at slowing the progression and maintaining quality of life. So emphysema, just talking about it more specifically, is loss of lung elasticity. So it's the loss of the ability to stretch. And then hyperinflation. So it gets hyperinflated from the air getting trapped down in the alveoli. This increased hyperinflated lung will flatten the diaphragm and weaken the effect of the respiratory muscles. So this causes a lot of impaired gas exchange. Patient has to use their additional muscles because the typical respiratory muscles don't work as well. So then you're going to see these people use neck, chest, all their accessory muscles to start breathing. Just a visual slide to just kind of differentiate chronic bronchitis and pulmonary emphysema. So I feel like Heather described this all very, very well, and just that inflammation of the bronchi. And she talked about every time you inhale on a cigarette, how it is an irritant, and the body's trying to has an inflammatory response to it. Same thing happens with other irritants as well. If it's somebody maybe who works in a factory that has a lot of irritants in the air, it's the same thing when they inhale that. Every time they inhale that, your body kind of has an inflammatory response to it, and it becomes a chronic problem that causes inflammation in the mucosal of the airways. And then they start having a lot of this thick mucus. And then if they're a smoker, if you remember, like the cilia along the bronchioles, they lose their ability to help move the mucus along. So they're pretty compromised in that situation. Again, I think Heather really touched on this very well, so I'm not going to go into it that much. The passive smoking, I don't remember if she mentioned that or not, but that is true. That's something that we cannot forget. Maybe they don't smoke, but maybe they've lived with somebody who smokes for a very long time, so they could have the same amount of damage. Actually, they're saying now that they have worse damage. And then there's that third-hand smoke that they're talking about, is smoke that's left on people's clothes and hair, and everything that can also contribute. So the combination of the inflamed airways, the progressive inflamed airways, the progressive loss of lung elasticity, and the ability to exchange gases is going to lead to hypoxia and tissue anoxia. It's basically they're just not going to get enough oxygen to the tissues if they don't have that good gas exchange. Acidosis is related to the retainment of CO2. CO2 is an acid. So if they're retaining it in their alveoli, they will become acidosis. And we know that our body does not like an acidic environment. Our body fights to get a neutral pH. So that's where we'd like to be. So that's why the body will kind of fight for to try to compensate if the patient is retaining a lot of CO2. Respiratory infections, they're at more risk for that. They don't have the ability to fight off, germs. They don't have the good coughing ability in order to, cough that stuff out of there, and they're at high risk for getting pneumonia. Cardiac failure is related to the more work of the lungs, and if you think about that cardiopulmonary system, the heart pumps blood to the lungs, so they're pretty closely related. So cor pulmonale is right-sided heart failure. So the right ventricle has to push blood into the lungs. And when the air has less, or when the lungs have less elasticity and they become a little less compliant, the right ventricle has to work harder in order to get the blood to the lungs to be oxygenated. So it causes this extra workload on the heart can cause right-sided heart failure. Cardiac dysrhythmias are typically related to the hypoxia. The decrease in the oxygen to the heart muscle can lead to cardiac dysrhythmias and other cardiac disorders. Okay, in order to assess a patient for the risk for a COPD, just think about all the risk factors that would be involved. That's what you would find in their history. Of course, cigarette smoking is the greatest risk factor for COPD. A patient with an 8-pack-year history usually has obstructive lung changes, but really no manifestations. Patient with a 20-pack-year history or longer often has early-stage COPD with changes in their PFTs, or pulmonary function test. Also in their history, you would look at their occupation, whether they've been exposed to other irritants in the environment as well, if they live with a smoker, things like that. General appearance, think about all those signs and symptoms. That patient, typically a COPD patient, is going to be working a little harder to breathe, productive cough, frequent productive cough. They could, if it's severe, have that barrel chest, that increased size in their chest diameter. Also, a lot of times they're thin. They're very thin because of working so hard to breathe. It requires a lot of energy and calories. So oftentimes they'll be malnourished. Respiratory changes, certainly you're going to hear abnormal breath sounds. So just think about what those breath sounds would sound like with somebody who has a lot of mucus in there. Also, the alveoli, when the alveoli are trapping air and the airways are constricted. All those different abnormal breath sounds that you're going to hear. And then they have, again, like we said, they have the pulmonary, or they have the cardiac changes that could occur. So right-sided heart failure, or something you might see with someone who has severe COPD. Other physical changes that you might see is like clubbing, and that's like a thickening of the ends of their fingers, and a lot of times that's due to long-term cyanosis. This is just a type of tool, this dyspnea assessment tool. It kind of goes along the lines of the presentation that Heather talked about, of how they do they have like an assessment questionnaire. It's measurable. We like things that are measurable, so it gives us sort of an idea, so we can, okay, if whether you're having shortness of breath now, or it's as bad as it can be, and where does the patient stand on that line there. And then after treatment, we could see if we get them to where they would prefer to be. So it's just like that questionnaire that she shared with us. It's sort of a tool that they use to determine whether somebody's getting worse or getting better. And it's a good tool for the patient to see themselves whether they're getting worse or better. So laboratory assessment, of course, ABG, that's your arterial blood gas. That is going to give us a good picture of how gas exchange is occurring in the patient. And that's pretty much all you need to know about that for right now, the purpose of doing an ABG. Sputum samples, you already understand that. Basically we're just seeing if there's any kind of bacteria involved that we need to treat. CBC, if their white blood cell count is elevated, it would indicate an infection. The other piece of that is something called polycythemia. A patient that is chronically has COPD could begin to have polycythemia, which is a compensatory mechanism where the body increases the production of red blood cells in response to detecting a low oxygen level. And we know that the red blood cells carry oxygen to the tissue, so if the body is saying we still need more oxygen, it will attempt to make more red blood cells to carry the oxygen and attempt to get more oxygen to the tissue. So polycythemia on a CBC would be increased number of red blood cells. Serum electrolytes are just going to assist the patient and the practitioner in determining dehydration levels, things like that. Chest x-ray, again, will give us a little bit closer picture of determining exactly what's going on in the lungs. And then the pulmonary function test, I think we've covered pretty well. Just basically it tells us, very specifically what the volumes a patient can breathe in, what they can breathe out. It's basically how well they are exchanging air and gases. So interventions, our whole goal of treatment for a patient with COPD is to help them maintain their oxygenation level, to maintain their quality of life. It's really aimed at keeping them out of the hospital and keeping them functioning and quality of life. And we can do that by teaching them and helping them to use their medications correctly, and just assisting them with coughing and deep breathing, making sure they have some type of exercise to keep moving around, to sort of like the pulmonary rehab over there. We're going to get them at least moving as much as they possibly can for as long as they can. Preventing weight loss, think about all the things as an intervention that you could do. A lot of times preventing weight loss is done by providing high calorie small meals. The reason that they do that is because people with emphysema and chronic bronchitis have difficulty eating a large meal, and that's because if you think about all the work that the heart and the body does to digest large meals, it would just be added work on the heart and lungs if they eat large meals. So the idea is to give them small, high-calorie meals in order to maintain their weight, because they can typically tolerate small meals better. And if you give them small meals with a lot of calories in it, you should be able to maintain their weight. And a lot of times you can do things like those supplemental shakes and things like that too. Those are good with high calories in them because they're burning a lot more calories by working so hard to breathe. Of course, minimize their anxiety. Heather alluded to that, and I don't know if any of you have experienced that yet, but people with COPD will be your most anxious patients, and they get highly irritable and anxious if that respiratory therapist isn't there right at every 4 hours to give them their breathing treatment. They will be very difficult to get along with at times because they rely on those breathing treatments. And when somebody feels like they can't breathe, they get a little bit testy because it's a very scary feeling. So you want to try to make sure that you, try to talk them through it, be supportive to get them through, any anxiety. Improve activity tolerance, and that's just again talking about pulmonary rehab, getting them to do as much as they can for as long as they can, and of course prevent respiratory infection. So coughing and deep breathing, moving around, all that stuff, and maintaining their nutrition is going to help them prevent infection. And of course, the typical stuff like washing their hands and staying away from sick people, they really need to do that, because once somebody with COPD gets a pneumonia, it's a very difficult thing to recover from, and it progresses their their condition each time they get pneumonia. It puts them, just kind of as another step back for them. So it's really important to make sure that we teach them to do that. Another thing on this topic is, as far as supportive care of a patient with COPD, is making sure you help them with breathing techniques. There's that pursed lip breathing, which Heather talked about a little bit. So in their nose, out their mouth. It's more effective in order to get that air down in there and get it through those alveoli. So pursed lip breathing is a very good way. So make sure you understand that. Positioning. There is a thing that if somebody sits up, they typically can breathe better. So a lot of them you will find are very comfortable. They sleep sitting upright at night, or they'll sit on the bed and they'll lean over the table a little bit. That helps them get the air down in there. You'll notice that they'll a lot of times be more comfortable sitting like that. There is a good chart on page 619 regarding breathing exercises. So just make sure you kind of review that and all that supportive care for a patient to help them to be as comfortable as possible. So drug therapy is very, very similar to the treatment for asthma. Again, you're going to have your beta-adrenergic agents, which are your bronchodilators. Your cholinergic antagonists are also bronchodilators. They just work a little bit different way. And remember, the cholinergic ones are the ones that are going to dry the patient out a little bit. So in some patients, it's a little bit contraindicated. Beta-adrenergic agents, remember, will make you a little bit jittery and make your heart race a little bit. So that can be kind of a side effect of that as well. Corticosteroids, of course, and an inflammatory response, it'll depress that inflammatory response. They typically like to give that as an inhaled steroid as opposed to a systemic steroid. NSAIDs, just for comfort. Mucolytics will help them get that mucus sitting down in the lungs, help them cough all that out of there. There are some surgical interventions that may be applicable for some patients. Lung reduction surgery can help improve gas exchange, and that's because they can remove some of that hyperinflated lung. Remember how Heather talked about them being hyperinflated, and so there's not much room for the air to get down in there, and so sometimes they'll remove a piece of the lung in order to improve gas exchange. The area of the lung that's filled with like stagnant air, they'll try to remove portion of that. This kind of a surgery used to be a median sternotomy. Now they've gotten it down to a VATS, which is a video-assisted thoracoscopic surgery. So they'll just kind of go through, it's like a smaller incision towards the side of the lateral side of the patient. Postoperatively, these patients are monitored very closely for respiratory, how well they rebound, essentially, how they're doing respiratory-wise, breathing, of course, their airway management, their oxygen levels, things like that. And again, they're going to have to cough and deep breathe as soon as they, wake up and start moving. They're going to have to do their IS to keep what's left of their lungs, open and healthy and prevent them from getting pneumonia. They typically have a lot of pain. That surgical incision on the lateral side of their chest can be very painful. And a lot of times they'll have chest tubes to drain any excess fluid and to reinflate the lung. So those chest tubes can cause a lot of discomfort as well. So they usually try to get those out fairly quickly as long as the patient doesn't have a whole lot of drainage or anything. Just another slide talking about dyspnea management. Just making sure that they eat small meals because that will help their dyspnea. And I think I talked about high calorie meals. It should also be high calorie, high protein foods. That's always good for them to kind of keep up their strength and their weight. A lot of dietary supplements. There's one called Pulmonary that provides nutrition with reduced carbon dioxide production, because we know that they already have high carbon dioxide levels typically because they're retainers. So high calorie, high protein foods with as a reduced amount of carbon dioxide production as possible. So lots and lots of different things that are needed to keep this patient at home and out of the hospital. Sometimes they have to use oxygen at home, so that's a teaching opportunity there. And then it's you have to teach the patient and the family how to maintain their oxygen, making sure they have it, making sure they have the means to have it. And then pulmonary rehab, which Heather talked about, is a great thing for them to keep them doing what they can for as long as they can. And they do a lot of teaching as well. So this is not something that they're going to get over quickly. They're going to have to continue to manage it for the rest of their life. They're going to have to understand their drug therapy, especially, like I said, again, like the maintenance inhalers. They need to make sure that they continue to take those. And then if they start to have signs and symptoms of infection, they need to call right away, because we know that they're going to get sicker quicker if they don't do something about it quickly. Again, the breathing techniques and the relaxation therapy are great ways for the patient to maintain their quality of life. Okay, this is just a quick mention of occupational pulmonary disease, which we sort of touched on briefly, talking about different toxins in an air where a patient may work. So basically, it's just pulmonary disease that's caused by things that are things that a patient works with every day. A lot of it is if people work in like a woodworking area, painters, things with gases and vapors, things like that. So it's really important that these patients know that there is a risk for being put into a pulmonary disorder, and they need to be making sure that they are provided with the appropriate prevention pieces. So most areas that employ patients that work in an area that's been identified as a place that's has these environmental hazards should provide the proper tools for the patients to prevent being exposed. A couple of those important prevention things would be the use of special respirators, something to put on their face to prevent them from inhaling the toxins, and then also ventilation in the facility that they're working in. That's the best way to prevent them from acquiring a pulmonary disease related to these environmental hazards. If those are not effective and the patient begins to develop some kind of a pulmonary disorder, a lot of times they have asthma-like symptoms initially. So if they start to do this, then if it might not be the job for them. They may have to try to find some other type of an occupation that has less hazards. So I'll just kind of talk about lung cancer for just a few minutes. Basically, we've talked about cancer. We know what cancer is. Lung cancer is the leading cause of cancer deaths worldwide. Most of them are bronchogenic, which means that they arise from the bronchioles. A lot of it is thought to be related to smoking, exposure to smoking for several years. The overall 5-year survival for all patients with lung cancer is only 14%. So there's poor long-term survival for this. So really, a lot of nursing care is directed at prevention of acquiring lung cancer, because it's hard to treat and oftentimes has a poor prognosis with it. We talked about all the staging and what all that means. module 2, I think. But, stage 4 would be a tumor that has spread, metastasized more extensively than like a stage 1. So just kind of pull that forward a little bit. And treatment, of course, is going to be depending on the type of cancer, how far it's spread, and so forth. Chemo and radiation are definitely the treatment that's probably going to be the most prevalent. There are some surgeries out there that a patient could have a portion of their lung removed, or there's transplants out there now as well. But typically it's a removal of portion of the lung where the tumor is. So like I said, really the nurse's biggest part in lung cancer is the prevention end of it. Of course, we're going to promote smoking cessation. And, I told you in the earlier part of the chapter, there's some information on how to walk a patient through smoking cessation. And you have to really do it in a very non-judgmental way. You have to, approach them in a way that it's something that they need to do to stay healthy, to try to, stay around for their family, because there is known connection between this and lung cancer. So it's really, just kind of talk to them about, what can we do to help you quit smoking? You really should. And what can we do to help you? Lung cancer isn't always terribly obvious to diagnose. A lot of times it's found on accident. Maybe somebody has had recurrent pneumonias. Maybe they have a COPD, they're getting worse, and they're getting recurrent hospitalizations. They'll do a chest x-ray or CT scan and find a tumor. That way it's not typically the first thing that people suspect. It's usually after several different illnesses that leads to the diagnosis of lung cancer. Some things that might elude the practitioner to suspect it would be several hospitalizations related to pneumonia or a pulmonary problem. And then sometimes later in the disease they'll develop some blood-tinged sputum. And then they'll just, continue to have respiratory compromise that's not getting any better, and that will elude the practitioner to maybe suspect that they have gotten some lung cancer. And thinking about the physical assessment of a patient with lung cancer, if there's a tumor in the airways, it would probably diminish the airflow, so you could have decreased breath sounds. If it's partially obstructing the airflow in the bronchioles, you could have wheezing, which again, like I said, these are all abnormal breath sounds that you might hear with other conditions as well. So it's not always obvious that a patient has lung cancer, and it's typically not found until we do more scans. So again, this is a cancer, so psychosocial is, monitoring a patient for how well they are dealing with a potentially very poor prognosis, and also maybe potentially facing a surgery or chemo and radiation. So it's very important to kind of determine how they're dealing with it, what kind of a support system they have. Sometimes people feel guilty about the fact that maybe they have smoked for a very long time, and maybe they feel guilty that possibly they did this to themselves. So we want to make sure that we don't make them feel that way, that we help them be supported and make sure that their family and any kind of religious support is there for them. We have talked about all these different kinds of treatments for cancer: chemotherapy, targeted therapy, radiation therapy, photodynamic therapy. We know that there are several potential side effects of each one of these, and so it's all the same kind of care. As far as radiation therapy, there's skin care involved in that. There's markings that they would have to go through to make sure they're marked so that the radiation hits exactly where it's targeted. Chemotherapy, again, has several side effects. So, you'd have to educate your patient regarding that as well. These are all surgical management options. Lobectomy is a removing part of the lung. So maybe if the tumor is kind of contained in a portion of the lobe, a certain lobe, they can remove it. And typically patients do okay with, a portion of their lung removed. It's a pretty extensive surgery. Again, typically these days they can do with a video-assisted lobectomy. Sometimes they can do it that way, so it's a little bit less extensive surgery, but can be a very painful surgery with a chest tube placed, which we'll talk about in a minute. Pneumonectomy is a removal of an entire lung, which people could and do go with one lung. So that would only be if the cancer has been contained within one lung, has not spread to other areas, that they could potentially just remove that and the patient could, function. Now, there would still be somewhat compromised with one lung, but it is something that is an option. You can also remove segments of the lung, which would be a segmentectomy, or a wedge resection is removal of a very small peripheral portion of the area of disease, a very small section, and they can do that with the video-assisted thoracotomy incision. I think you have some pictures on 634 of these incisions that you might see with a pneumonectomy. So they're pretty extensive incisions if you look at them on the lateral side of the body. And then a chest tube would be placed post-operatively to help drain any kind of bleeding from the area and also to help reinflate the healthy lung. These are those pictures that I was talking about that are on page 634. So these are the incisions that they could have right here. So it's pretty painful. And then after post-operatively, we're trying to get these patients up and getting them to take deep breaths and such. So, that's painful, especially if you have a chest tube coming out of one of those incisions there. It's really hard for them to breathe and get up and move around. Splinting, I don't know if you recall talking about splinting before. It's very important. Basically, they can hold a pillow kind of against this when they get up and down, and when they cough, and it splints the area and kind of provides support so it doesn't hurt as bad. It's just a picture of a sternotomy right here. They don't do these as much anymore because they've come up with the VAT surgery, so they don't have to, because a sternotomy means that we cut through their sternum with a saw and then we wire it back together. It's pretty painful surgery, so thank goodness we don't have to do that as much anymore. It's just a picture of a chest tube placement, and what chest tubes do is remove three things. It can remove air from the pleural cavity, it can remove fluid from the pleural cavity, or it can remove like pus or drainage or bacteria. So don't get too caught up in this. Just know that it could be placed post thoracotomy or a thoracic surgery, and it's just to drain some of that stuff out of that pleural cavity. Because I want you to think about this. Think way back to your anatomy. So this is your pleural space right here. If fluid gets in there, say my red, what I'm putting on there is fluid. Basically what it does is it pushes on the lung. And then the lung here cannot expand as much as it does. So what these tubes, say they're showing you like a drainage tube here and a drainage tube here. And if you notice, the one down lower is a good place to drain fluid. So what that would do, that tube, it would just drain that out of there so that the lung can reinflate. The tube that they put in up higher would be for air, and that's all about gravity. Because sometimes air from the atmosphere can actually get in here, and can you imagine if we're in here opening up that last incision that you saw? If we open this up, it can allow air into this cavity as well, and if there's air from the atmosphere in that cavity, then it collapses the lung as well. It pushes on the lung and it can collapse it. So they put a tube in there to add a little suction to, and they can get that air out of there, and then the lung can reinflate. So that's just the purpose why you would see chest tubes post-operative surgery of a thoracic surgery. Here's my 3 things that needs to be done. And I don't want you to don't get hung up on this. I don't actually, just look this over, but don't worry about this portion of it just yet. Like I said, it's pretty much what I just said. It collects fluid from the patient, and you just basically have to make sure it has a water seal on it. I think I have a picture of it in the next slide, so we'll just look at that really quick. Again, just take a peek at this, but I would not even worry about this because you're going to get more on this in the 200 nursing classes. These are just pretty much the typical things that you would worry about with most patients who've had surgery. But remember, if you have somebody that's had some type of a long surgery, then your respiratory management is going to be a huge priority for this. You're going to maintain their airway, maintain their coughing and deep breathing. And the really big thing, pain management is number 1, if you notice up here, because you looked at those incisions and they're going to have a lot of pain. But we also want them to breathe, cough and deep breathe. But if they're in a lot of pain, they are not going to do that for you. So you have to get their pain under control and then ask them to cough and deep breathe. And then the pneumonectomy care would be, like bandages. So this is, making sure that, any dressings are changed and maintained and all that good stuff. So that's everything for the non-infectious lower respiratory disorders. I hope that kind of pulled it all together for you. I highly encourage you to do the next slides with the case studies and practice questions.